Hello, I'm Cindy Rapp from Denver, Colorado, and today we're going to be talking about sonography of abdominal wall hernias. Sonography of abdominal wall hernias. A hernia is a protrusion of an organ or tissue through an abnormal opening in the body. Not all hernias contain bowel loops. Fat is the most common sonographic hernia content that we will see. Now, where do hernias occur? Areas of natural weakness in the abdominal wall, basically anywhere that plumbing goes through. So the internal inguinal ring, the inguinal canal, the femoral canal, the fetal canal such as the umbilical ring, anywhere there's aponeurosa. These typically will be direct inguinal hernias, Spigelian, or defects of the linea alba, and also anywhere that there has been a surgical scar, a hernia can occur. Some of the causes of hernias are increase in intra-abdominal pressure due to obesity, chronic coughing, lifting heavy objects, patient straining, constipation, pregnancy, and ascites. Now, what's neat about sonography, we can determine not only the location or the type of the hernia, we can determine the actual contents, if those contents are reducible, or if they are strangulated. Looking at abdominal wall hernias, this netter illustration, you can see that inguinal hernias, there are direct and indirect inguinal hernias that we'll talk about, umbilical hernias, femoral hernias occur below the abdominal crural crease, we'll take a look at those. Spigelian hernias are another type of hernia of the aponeurosa that we'll talk about, and epigastric hernias. Any type of a hernia that is midline above the belly button is an epigastric hernia, and hypogastric hernias occur below the belly button. Incisional hernias are another type of hernia that we'll also take a look at. Hernia contents can be intraperitoneal, and those could be fat, fluid, bowel vessels, and membranes, or you may have a hernia that is only properitoneal. These tend to be fat-containing only hernias, and I'll describe what or how we evaluate properitoneal hernias. Then we can not only tell the contents of the hernia, are the contents incarcerated, does the patient have a bowel obstruction, or is there incarceration of the hernia contents? So looking at these different images, we can see the image on the left is a fat-containing hernia. The image in the middle contains fluid and also a loop of bowel that is projecting into the contents. And then the image on the far right, we can see that there are blood vessels and membranes, and with color Doppler we can see that there's still flow, so we know this is not a strangulated hernia. Hernia contents, we can also see shadowing gas within loops of small bowel, and we may see peristalsis within some of these hernia contents. This is an indirect inguinal hernia that we can see peristalsis of a loop of small bowel through the defect in this inguinal canal. Now, when we talk about pre or properitoneal fat, if we're scanning hernias of the midline or the linea alba, everybody has a little layer of fat that sits between the peritoneal membrane and the linea alba, and this is referred to as properitoneal fat. What can happen is you get a defect through the linea alba, but the peritoneal membrane is still intact. These are very common. The patient will present as a palpable abnormality, and rarely are these hernias reducible. Here you can see the peritoneal membrane, we have the linea alba, and you can see the defect. It almost looks like a mushroom cloud extending up. This patient presented with a palpable lump that was a preperitoneal hernia only, which means there are no intraperitoneal contents, so the patient really is not at risk of getting strangulation of intra-abdominal contents with this type of a hernia. A lot of these midline linea alba defects are non-reducible and they are non-strangulated. So here's a transverse view between the two rectus muscles. The peritoneal membrane can be seen here. This is the linea alba, and you can see the defect right through this area. Rotating the transducer 90 degrees, you can see the long axis view of the linea alba, and right through here it's a defect with just a little bit of preperitoneal fat on that particular patient. Now, with sonography, we can do dynamic maneuvers, we can do Valsalva, we can check for compression, or we can stand the patient upright. These are unique in the things that cannot typically be done with the patient in a CT scanner. Why do we want to use Valsalva maneuvers? Sometimes hernias are only symptomatic when the patient is standing or actually was straining. The conspicuity of fat containing hernias is typically poor. The motion or key to diagnosing these fat containing hernias, and hernia contents may change. So something that looks like it may be only a fat containing hernia, once the patient Valsalvas, we may see loops of small bowel that extend into the hernia also. So on this particular image on the left-hand side, we can see an indirect inguinal hernia with fat. Once we have the patient Valsalva, the hernia contents expand and actually move down the canal a little bit more. So we can see that with Valsalva maneuver, we definitely have an increase in the fat contained within inside this hernia. So looking at this loop here, we can see once again it's an indirect inguinal hernia that is fat containing. We can see with compression of the transducer, this hernia is completely reducible. Now, why will we use compression maneuvers? The conspicuity of fat containing hernias is also low. It kind of creates abnormal motion for hernia contents. The motion created by the compression is smoother than having the patient Valsalva. It's something else that we always want to check the reducibility of hernias. Some of the hernias may be present with the patient just in the supine position, so then we want to reduce those hernia. And it's a good way to check for tenderness. Hernias are a lot more common than clinically suspected a lot of times and may not really be the true cause for the patient's pain. So asymptomatic incidental hernias are very common, and significant hernias are usually tender. This was a patient that in supine position, we could see this small hernia extending up. We want to check to see if the hernia is reducible. So with transducer pressure, we were able to reduce that. Looking at this indirect inguinal hernia, with reducing or compression of the transducer, this hernia is partially reducible. We can see the loop of small bowel that goes down, but notice still down the inguinal canal are additional loops of small bowel, and this was a partially reducible indirect inguinal hernia containing small bowel. The reason we'll stand the patient upright is sometimes we'll see puddling of the peritoneal fluid, especially in female patients. When they ovulate, there'll be some fluid in there, so standing the patient up, a lot of times hernia contents will change. Gravity is more reliable than the Valsalva maneuver in some patients. Many hernias are symptomatic when the patient is in the upright position, and usually hernias are going to become larger when the patient stands up. Another thing is some hernias are present only in the patient in the upright position. This tends to be true for Spigelian hernias. Even if patients have a very good Valsalva maneuver, a lot of times we'll only see the Spigelian hernias in an upright position. Few hernias are reducible also when the patient is standing upright. Sometimes the neck may be pinched off with the patient supine, so standing them in the upright may change the position of the neck, and then a hernia may become reducible. This is a patient that when they were supine, we can see this fat-containing indirect inguinal hernia. Once we stood the patient upright, we can see that there's not only fat within the hernia, but now there is also fluid. So the difference in staying the patient upright, we're able to see additional contents within the hernia. As far as terminology, we prefer to use the term non-reducible rather than using the term incarcerated. The reason for this is clinicians get confused between incarceration and strangulation. All strangulated hernias are incarcerated, but most of your incarcerated hernias are not strangulated. So once again, rather than using the term incarcerated, we prefer to say that a hernia is non-reducible or incompletely reducible, rather than stating that it is incarcerated. So how do we find inguinal hernias? What is the key to diagnosing the landmarks for inguinal hernias? The key is to find the inferior epigastric vessels, and what we do is follow those to their origin from the external iliac artery. The inferior epigastric origin marks the origin of the internal inguinal ring. So looking at this Netter illustration, we can see these are the inferior epigastric vessels. He shows that there's a single artery and single vein, and actually patients have one artery with paired veins. So normally you're going to see 3 vessels just under the surface of the rectus muscle. What I'll do is typically start scanning in this area, and what you'll notice that as you slide your transducer more inferiorly, these vessels will move out laterally. So here's our first image. It would be taken about in this area. You can see the patient's rectus muscle. Here is the artery with paired veins just under the edge of the rectus muscle. As I move my transducer down, you can see the vessels start to move more lateral. As I keep moving down, you can see they're right at the edge of the rectus muscle just before they go into the external iliac artery. Right at this point, you can rotate your transducer in a long axis and a short axis view. If you notice, it's more to the crease of the leg and not straight longitudinal and transverse imaging on the patient, but more long axis to the inguinal canal and short axis. And so the internal inguinal ring is right at the location of where the inferior epigastric artery dives into the external iliac artery. In male patients, the spermatic cord can be seen within the inguinal canal. Females have the round ligament, but typically we don't visualize the round ligament very well on our female patients. Now, two types of inguinal hernias that can be seen. There is an indirect inguinal hernia and direct inguinal hernia. The majority of inguinal hernias are indirect, and the way to tell these, they go up and over, or in other words, they are superficial to the inferior epigastric artery. If you're scanning transverse over the spermatic cord, down a little bit lower in the inguinal canal, they will be anterior to the spermatic cord, and they may communicate with the scrotum. So typically, if you see a hernia contents that are in the scrotum, usually it will be an indirect inguinal hernia. Direct inguinal hernias are inferior to the inguinal ring. It is a defect through the conjoined tendon, and these tend to be more posterior and medial to the spermatic cord, so we will see them behind the spermatic cord rather than anterior to it. So this image we can see is a view of the left inguinal canal on a male patient. That we can see the spermatic cord located right here. We can see the spermatic artery, some of the veins within it, and then the echogenic area is just the fat inside of the spermatic cord. Your inferior epigastric, your iliac vessels would be off to the side of the image right over in this area. Indirect inguinal hernias will be anterior to the spermatic cord. Direct inguinal hernias are going to come up posterior and medial to the spermatic cord. You can see spermatic cord here. Once again, indirect inguinal hernias will be anterior, direct will be posterior and medial. Now looking at this loop here, this patient has got two hernias. There is a direct inguinal hernia located right here, and an indirect inguinal hernia was located right at the edge of the spermatic cord. Next, we're going to talk about indirect inguinal hernias. That is the most common type. They arise in the internal inguinal ring, superior and lateral, as they pass anterior to the inferior epigastric artery. So we follow those vessels from the rectus muscle down into the external iliac artery, and when a hernia courses up and over, those are indirect inguinal hernias. So we can see our inferior epigastric artery here. We can see the hernia contents extending down. This is a fat-containing indirect inguinal hernia. Rotating the transducer 90 degrees, we can see the spermatic cord is compressed here, and we have the hernia contents located here that are anterior to the spermatic cord. So not all indirect inguinal hernias will always be seen anterior to the spermatic cord. What can happen is they start out anterior to the spermatic cord, but as they travel down the inguinal canal, sometimes they rotate around and can be seen actually posterior to the spermatic cord. So here we see our inferior epigastric vessel. We can see the hernia contents coming up and over. In a short axis view, here we have the spermatic cord, but the hernia contents are posterior to the spermatic cord, and that's just because it has rotated posterior to it as it traveled down the canal. But this is still an indirect inguinal hernia, which is the most common type of inguinal hernia we'll see. Inguinal hernias may have a wide neck or may have a narrow neck. Patients tend to be more symptomatic when the hernia contents have a narrow neck rather than a wide neck. But here we can see a very wide neck indirect inguinal hernia that is fat containing. Looking at this loop, we can see hernia contents with very wide necked indirect inguinal hernia, fairly easy to diagnose on the cine loop. Narrow-necked hernias even can be fairly small, and the patients typically are much more symptomatic with these than they are with the large hernias. But here's our inferior epigastric vessel. We can see this small indirect inguinal hernia coursing up and over the inferior epigastric artery. So on this cine loop, when the patient valsalvas, We can see the small hernia coming up and over, so we notice the inferior epigastric artery is right here, and a small, narrow-necked, indirect inguinal hernia is seen coursing up and over the inferior epigastric artery. Looking at this in a short axis view, we can see the hernia contents, and this is actually compressing the transducer. We're able to push the contents back in. So this is on a female patient. We don't see the round ligament, but you can see a very small indirect inguinal hernia on a short axis view. Hernias can be very large, and if you have a hernia that's extremely large, going to a curved array transducer may actually be helpful to make sure that we get all of the hernia contents in. But this is a very large small bowel peristalsing hernia that is an indirect inguinal hernia that we can see there. And as I mentioned earlier, if you have hernia contents that extend into the scrotum, typically those are indirect inguinal hernias. So on this wonderful barium minima, we can see the contents extending down through the inguinal canal. This is a patient that came in because they had a palpable scrotal mass. We can see the top of the testis here, and when the patient Valsalvas, we can see this fat-containing indirect inguinal hernia extending down into the scrotum, and this turned out to be the palpable mass in the patient's scrotum that was diagnosed as an indirect inguinal hernia. Next, we'll talk about direct inguinal hernias. Direct inguinal hernias are right inferior and medial, and they never will pass anterior to the inferior epigastric artery. So here's our inferior epigastric artery that comes down into the external iliac artery. Instead of coming up and over that, such as the indirect, these tend to be more posterior and medial in location. Now, a precursor to the direct inguinal hernia is where we will actually see thinning and bulging of the conjoined tendon. It's not an actual hole through that, but these a lot of times will be also referred to as a sports hernia, and these patients are quite tender when they diagnose these. So this is looking at a transverse view of the spermatic cord. These are the hernia contents that are posterior and medial. When we rotate long axis view, you can just see the bulging. So normally this line would come straight across here. We can see bulging of the conjoined tendon. When the patient relaxes, you can see that that goes back in. But this is thinning of the conjoined tendon, sort of a precursor to the actual direct inguinal hernia. So looking at the long axis view, here we can see the inferior epigastric artery. Normally your indirect inguinal hernias are going to come up and over the inferior epigastric artery. This defect is posterior and medial. This is a true hernia containing fat that is posterior to the spermatic cord. So another example, you can see the spermatic cord, posterior and medial in short axis view is this direct inguinal hernia. Another patient with a fairly large hernia arises inferior and medial to, it does not drape over the inferior epigastric artery. So this is also a very large direct inguinal hernia. Looking at this loop, you can see this short axis view. The patient's spermatic cord is located right through here, and when the patient Valsalvas, you can see that on this right side we have this area that bulges up. This is just weakening of the conjoined tendon, not an actual defect. When we look at this in a long axis view, you can see that when the patient Valsalvas, this area bulges down but not an actual hole. So this is thinning of the conjoined tendon, sort of a precursor to the direct inguinal hernia. Next, we're going to talk about femoral hernias. Femoral hernias occur below the abdominal crural crease, and literature reports femoral hernias to be fairly rare, but we find them much more often than the literature reports. One reason is it's a tough diagnosis to make clinically. With inguinal hernias on male patients who can do the cough test, where the doctor will actually feel in the inguinal canal and see if they can feel hernias, whereas femoral hernias are deeper in location and much more difficult to evaluate clinically. The most common location for a femoral hernia to occur is medial to the femoral vessels, so right in this area is the most common location. But you can see all the different areas that a femoral hernia can occur. They can be anterior to or posterior, but once again, the most common or typical location is just medial to the femoral vein. Looking at this view, this is a short axis view of the left femoral canal. You can see when the patient Valsalvas, we can easily see the femoral vein and the artery, and just medial to that, we can see the fat-containing femoral hernia. So this is also with quiet respiration. You can see here's the artery, here is the compressed femoral vein. This is the area that we're going to see the hernia. Once the patient valsalvas, we can see the vein expand and the hernia contents that move just medial to that femoral vein. This is a patient that was nice enough to have bilateral femoral hernias. So on the first loop, we can see here's the femoral artery and the femoral vein. When the patient valsalvas, you can see a fairly large fat-containing femoral hernia just medial to the femoral vein. We look at the left side. These hernia contents are already out, so what we have to do is compress. Here you can see the artery and the vein, and you can see hernia contents coming and extending out. So this is using the transducer to compress the femoral hernia. Spigelian hernias are the next type of hernia that we'll talk about. If we look at spigelian hernias, they occur between the edge of the rectus muscle and the oblique muscles. And what we'll notice with spigelian hernias, you're going to have a tear of the transverse abdominis. Sometimes the internal oblique aponeurosa will also have a defect through it, but the external oblique will be intact. So here you can see on this patient with a spigelian hernia, we have the transversalis fascia that there's a defect, we have the internal oblique that there's a defect, and the external oblique is still intact. So the hernia contents are extending up here. This is the edge of the rectus muscle. These are the three oblique muscles. And here we can see this small spigelian hernia that was palpable on this particular patient. So looking at this left spigelian hernia, here we can see the edge of the rectus muscle. Spigelian hernia's most common location is right where the inferior epigastric vessels leave the edge of the rectus muscle to go down into the external iliac artery. Just lateral to that location, you can see that the spigelian hernia comes up, sort of a narrow neck, and is very superficial. Inguinal hernias tend to occur a little bit lower down in the canal, or I should say a little more posterior, but spigelian hernias tend to be more anterior in location. Here's another example. You can see the edge of the rectus muscle, the inferior epigastric vessels, and here we have a fairly large fat and bowel-containing spigelian hernia. Also notice how superficial this is, just under the edge of the skin, just lateral to the inferior epigastric vessels. So these occur only a centimeter or two away from the origin of the internal inguinal ring, and many times these are mistaken as inguinal hernias instead of spigelian hernias. The way we can tell the difference, typically we'll image a spigelian hernia in the transverse view. You can see here's the defect, and notice how superficial this occurs, where your inguinal hernias tend to be more of a hernia content if you're in a transverse view that comes straight out at you. In transverse, you typically do not see the neck like you do on a spigelian hernia. So this is looking at an inguinal hernia versus a spigelian hernia, and they are very close proximity of where both of these will occur. Next type of hernia we'll talk about are ventral hernias. If the hernia is located above the belly button, those are called epigastric, and any type of hernia below the umbilicus is going to be a hypogastric hernia. So if we look at the layers, we talked about properitoneal fat or epigastric hernias, normal amount of fat that's within there, but we can also see fat that comes in that we'll see properitoneal fat. So scanning a patient midline, this is what we're going to notice is one rectus muscle here, the other rectus muscle. This is the normal linea alba. This is the peritoneal membrane, and this is the normal preperitoneal fat that we will sometimes see on patients that get a defect. So what happens is you'll get a defect through that area, and it'll look just like a mushroom cloud coming up, but the peritoneal membrane itself will be intact. This is a patient that we can see has a small preperitoneal hernia, and what we're doing is actually have the patient breathe in and out. We're trying to compress. This does not reduce at all. You can see that the linea alba has the defect right through here, but the peritoneal membrane is intact. So most of the time when you have a non-reducible hernia, it is going to be one of these preperitoneal hernias with just a defect through the linea alba only. This is a patient that has a strangulated or incarcerated non-reducible hernia. Here is the umbilicus. This is an epigastric hernia. The patient was very tender. You can see that once it becomes strangulated, the fat typically becomes more echogenic rather than being more isochoic. This is a patient that had had a previous hernia repair. You can see the mesh here. She had delivered triplets. They wanted us to reevaluate the linea alba, and you can see she has multiple defects through here. So a patient, in doing this scan, we can see that not only did she have this mesh that had repaired some of her hernias, but now she had 3 additional defects through the linea alba that had not been repaired the first time. This is a patient with a very large reducible defect through the linea alba. You can see this is a quite obese patient. We're using a curved array transducer, a very wide defect through this area, and this contained fat and small bowel that we could reduce this very large epigastric hernia. Looking at umbilical hernias typically are just incomplete closure of the umbilical ring. We can see this very large umbilical hernia on this patient that has ascites. When the patient Valsalvas, we can see that a loop of bowel extends up and we get blood flow within that. This is a patient that knew he had an umbilical hernia. He was out mowing his lawn and had some severe pain and actually sort of strangulated the hernia, became more echogenic. When you compare strangulated fat that is echogenic to normal fat tends to be more isoechoic. So one way we can tell the strangulated fat on ultrasound is look for this echogenic fat. Typically we won't see any blood flow in this area, and the patient tends to be more tender. Usually these can be fairly large, but the patients are usually asymptomatic other than they have a palpable lump. Here's a patient also with a very large umbilical hernia. You can see this patient has quite a bit of massive ascites. We can see this loop of small bowel and all the fluid that's extending up in this fairly large umbilical hernia. Incisional hernias can occur anywhere the patient has had prior surgery. One thing to remember is now patients have more and more laparoscopic procedures. So anywhere that they have had a trocar site, they can actually develop a hernia through, and it may be difficult to sometimes locate these areas. This is a patient that had one of the good old-fashioned gallbladder scars that used to extend halfway across the abdomen. And in scanning over that site, we were able to see this fairly large incisional fat-containing hernia along an old gallbladder incision. This is also a hernia that we can see intraperitoneal contents, and we can see between the different muscle planes we've got fat that extend and then fat that extends down both ways. So an incisional hernia that we can see different components of the hernia extending. A lot of times we're asked to evaluate patients that are post-op and scan over the mesh. Now one thing, when you're looking at mesh, you will not get a hernia that occurs through the mesh. What we want to do is scan anterior, superior, I should say, and inferior, medial and lateral to the mesh, but nothing will protrude or you won't get a defect through the actual mesh. This is what mesh will look like a lot of times on ultrasound. You just get an area of shadowing behind it, but the defect will not occur through the mesh when we're scanning these patients looking for recurrent hernias. So on this loop here, we're looking at the upper edge of the mesh. You can see the mesh located right through here, and when the patient Valsalvas, we have a very small fat-containing hernia right at the upper edge of the mesh. So this is a recurrent hernia just superior to the edge of the mesh, and that is kind of where you want to look for recurrent hernias, is not directly over the mesh but all around the edges of it. So what are some things that can give us false positive diagnosis for hernias? Clinically, patients can present with a palpable groin lump, or they may present with pain. So things that we can see would be a spermatic cord lipoma. We can have tunica vaginalis cyst, round ligament varices. Patients may present with a palpable lump that are normal lymph nodes. They may present with pain that is actually diverticulitis, and actually examples of a rectus hematoma. Patients have been referred to ultrasound to rule out a hernia when they tore their rectus muscle. This is a patient that has a spermatic cord lipoma. It's fat-containing and non-reducible, so we can compress this. We don't see a neck to it, and this was a patient with a spermatic cord lipoma. Tunica vaginalis cyst can also occur with a patent process vaginalis. A lot of times you'll be able to see these cysts. Patients will present with a palpable abnormality, and one thing to be concerned or to be aware of is that they may have a tunica vaginalis cyst. This is a patient that has a tunica vaginalis cyst and we can actually reduce it. So there is a defect or a hernia. They came in because they felt this cyst, but you can see with probe pressure we're able to reduce that. But a mobile tunica vaginalis cyst on this patient with an indirect inguinal hernia. Something else that we can find on ultrasound are round ligament varices. Now, a lot of people are not aware of these, but a lot of times patients will come in their third trimester of pregnancy with a palpable lump in their groin, and what they have are varicosities of the round ligament. The round ligament is a suspensory ligament for the uterus, and it will mimic a hernia. When the patient stands upright, these will get quite enlarged, and clinically the physician will think that the patient does have a hernia. If you only scan the patient in a supine view, a lot of times you'll not make the diagnosis of round ligament varices. But here you can see in a short axis view of the right inguinal canal, and then with a little bit of color Doppler we can get blood flow within those round ligaments. This is a patient that came in with a palpable lump. I also want you to notice that this patient has zero, hardly, subcutaneous fat. She was a marathon runner, and when she came in with her palpable lump, this is just a normal groin lymph node. We had told her that if she probably had as much fat as normal patients do, she never would have felt this, but we can use color Doppler and see the vessel feeding the hilum. But this was a perfectly normal lymph node on somebody who was just a marathon runner and had hardly any body fat, and that was one reason she was able to palpate this mass, and her doctor just wanted to make sure that it was not a hernia that she had in the groin. This particular patient presented with left lower quadrant pain. His physician wanted to rule out a hernia. We scanned him for a hernia, did not find one. He goes, yeah, but my pain is not that low. He goes, my pain's up a little higher. He pointed to the area of tenderness, and right here is an inflamed diverticulum. We can see a little bit of inflammation surrounding this, but this was a case of diverticulitis. This next patient was a lady who decided she needed to lose some weight, went and saw her physician. He put her on an exercise program and kind of gave her a little bit of a challenge. Said, I want you to try and do 100 sit-ups a day if you can. Well, she said, you know, that kind of a challenge, she was going to be sure and do it, and she got through about 15 of them and got severe abdominal pain, but wasn't going to quit because her doctor had given her the challenge. And she came in for an ultrasound the next day, bent over. What she had done was torn her rectus muscle. This is looking at the right rectus muscle. This is looking at the normal left rectus muscle. And she has this very large rectus hematoma just from doing sit-ups, sort of a challenge from her physician. And she was negative for a hernia. This is a newborn patient that we were asked to scan in the intensive care nursery. One of the sonographers went up and scanned and said the patient has a little lipoma. So going back up to check this patient, in scanning through that area, what we found was they actually had a very small defect of the linea alba. Here you can see that the peritoneal membrane is intact, but there's a very small defect through the linea alba, and who knows how a newborn got a very small linea alba hernia, but there was a defect there. Now, something else that we'll see quite often, patients will present with a palpable lump midline that is called diastasis recti. When they raise their head up, they get this bulge for the midline area, and a lot of clinicians think that these are hernias, but all it is just separation of the rectus muscles. So if we look at this image scanned across, instead of the rectus muscles being fairly close together like they normally are, we can see the edge of one here, the edge of the other one. This is the linea alba that's all the way across, and when the patient sits up, they just get bulging of these intra-abdominal contents, but there's no defect. So if you're ever asked to scan somebody that has a bulge in mid-abdomen, it is not an actual hernia, but just called diastasis recti. Last thing I want to show you is a patient. This is a 43-year-old patient that came in with left groin pain. Indication was to rule out a hernia. So here we scan a long axis view. We can see our inferior epigastric vessel right here, and we can see this content that goes up and over the inferior epigastric artery. So it appears to be an indirect inguinal hernia. So what are the types of things we want to do in looking at this patient? First thing we're going to do is have the patient Valsalva. So in having the patient Valsalva, do the contents look like they changed? Not really. Next we try compression. So here's our inferior epigastric vessel. We compress down. Does it look like it changed? Still didn't look like it changed much. What's the next thing we want to have the patient do? We'll have them stand upright. So here we can see this area supine with color Doppler. We have the patient stand upright, and now what we can see are these round ligament varicosities. Another thing is to always be sure and ask your patient how are they positioned or what are they doing when they notice their symptoms. If they say they notice the bulge in the groin when they're in the upright position, it's very important to make sure that you scan the patient in the upright position. Now, round ligament varicosities are usually bilateral, even though the patient may only present with symptoms on one side. So I will typically always scan the patient on both sides and look at these when I try and evaluate patient for round ligament varices. The other thing is if a patient comes in to rule out hernia, their symptoms are on the right side, I will scan the right side for hernia. I'll scan with and without Valsalva maneuvers, stand the patient upright if I do not see any hernia with that. If I still do not diagnose a hernia, I'm done. I don't take a look at the other side. But when they come in with right lower quadrant pain and we're asked to evaluate that side, if I find a hernia on the right side, I always go over and check the left side also. A lot of hernias do occur bilateral, but if their symptomatic side is negative, I don't want to open up a can of worms and take a look at the other side, but we will check bilateral if their symptomatic side was positive. I want to thank you for your attention, and hopefully this was very helpful.